Hey, good afternoon, everyone. Friday afternoon, yay! I'm just going to make a few announcements before I turn it over to my colleague, Kim, who's going to moderate this fabulous panel we have coming up. Just a couple of announcements. What a great conference this has been so far. It's been so great seeing you all learning in your workshops and then coming together again for the plenary sessions. Tonight, we have a health equity networking reception that starts at 6:30 in the Thornton room. So that's, you go past the hotel registration desk in those cold, chilly elevators and go all the way up to the 11th floor. And there's a health equity networking reception that we invite you to go to this evening. I also want to put in another plug. I know I've been talking about it a lot. I helped to plan it, so I'm very excited about the plenary tomorrow morning. It's the intersection of social media, digital strategy, and healthcare, and I guarantee you it is going to be entertaining. I've talked to our speakers. They're going to be, you're going to learn a lot, and you might even laugh a little bit. That is where activist and artist Regina Holiday will have a painting that we're going to be raffling off for those of you who have been tweeting your favorite things about hashtag HA 2014, Health Action 2014. I've been monitoring it, and you guys have been great. So that is tomorrow morning, and we'll see you there. I have another announcement, and this one is targeted for you who are here local. DC Healthcare Policy Wonks. There is a set of us who are going to be learning how to be a CAC and get out into Virginia, where there is a great need. So there's a few of you who have come to me and asked me to make sure to plug for this crowd. If you want to be plugged into that, we can get you out trained and certified and out there connecting in the community right away. And the person you should email if you are interested in this, and here's the funny part, she doesn't know I'm giving out her email, is Elaine Sally on our staff. And the way you reach Elaine is her first initial and last name. So it's ESALY at familiesusa.org. ESALY at familiesusa.org. If you're a DC policy wonk and you want to get out and learn to be a CAC in Virginia. I think that's all I have for now. Kim, I'm turning it over to you.
Good afternoon, everyone. I hope you're enjoying Health Action 2014. I can't believe it's already Friday afternoon. It's gone so fast. It's been so good to catch up with all of you. As most of you know, I'm Kim Bailey. I lead system improvement work at Families USA. And Families USA, as you very well all know, has been an organization committed to increasing access to coverage for more than the last 30 years. So getting into this territory of system improvement is new for us. And as I've started talking about health system improvement being this new area for Families USA, many of you have asked me, what exactly do you mean by system reform? That's an excellent question. The system is huge, and reforming it can mean many different things. It can mean changing the way we pay providers, helping to bring healthcare costs under control, improving quality, achieving better healthcare outcomes. That's all encompassed in improving healthcare systems. So where does Families USA fit into this? We continue to refine our vision as we move forward, but one thing is very clear. In order to make the system work better, we have to change the culture of medicine, from research to the patient-provider relationship, to the way that care is organized, delivered, and paid for. And doing this effectively will require engaging patients, providers, and all of the other stakeholders in the system. So that's what we're here to discuss today. How can we engage consumers and providers to drive health system improvement across the continuum of care? So before I start introducing our first speaker, I want to point out that there are cards in the center of the table. And if you have a question as we go, please fill out that card and send it to who's going to be collecting cards. Kate Blocher here at the front will be collecting cards. So hold it up if you have a question as we go, and we'll get to questions at the end. We're going to begin today with the discussion of patient engagement in clinical research. How many people in this room have heard of PCORI? Please raise your hands. I'm really excited to see that. How many people are following the work that PCORI is doing closely? Raise show of hands. If you're not, you need to be. It's incredibly innovative, and they're doing a great job to engage patients and other stakeholders in the generation of research. That's new and that's groundbreaking. And we have Dr. Ann Beal here today to tell us about that. Dr. Beal is a pediatrician and public health specialist who has dedicated her career to increasing access to high-quality health care. She has worked as a provider in underserved communities, as a health services researcher, as a policy expert on disparities in health and health care, and as a funder. And like many accomplished women I know, she wears many hats, including 2 currently at PCORI, where she is both Deputy Executive Director and Chief Officer for Engagement. It's that role as Chief Officer for Engagement that I think is so exciting and that I hope she can fill us into today. In that role, she is charged with ensuring that the voice of patients and other stakeholders are reflected in the work that PCORI funds. And as someone who's been working closely with Dr. Beal and her team as part of PCORI's Patient Engagement Advisory Panel, I can assure you that PCORI is taking that very seriously and that Dr. Beal is working tirelessly to achieve that charge. So with that, I'd like to introduce Dr. Ann Beal.
So what Kim failed to mention among my achievements is that I survived adolescence. I have 2 adolescent daughters who are now out of my house. So I'm sure all the adolescent mothers can relate. So thank you, Kim, and thank you, Ron, for inviting me to come and speak to you all at Families USA. So I know that Kim asked how many have heard of PCORI and how many have been following PCORI, but how many have applied to us to be reviewers? Not as many. How many have applied to us to participate in any of our advisory panels? Okay, so my job here is to change that. So as you heard Kim say, I think part of what Families USA is now thinking about is they're now turning their attention and focus to issues of health systems and systems improvement is what is the role of patients in that. So knowing the work of my esteemed colleagues who are here tonight, I know that you're going to hear about not only the work that we're doing around patient engagement and research, but you're also going to hear about patient engagement, participation, and partnership in terms of care and in terms of systems and systems improvement. And so oftentimes people don't really think that much about research and the importance of research in terms of health and health care. And I think oftentimes patients don't really think about the role that they can play in that. But I'm here to really share the word of PCORI and to really make people start to think about what are some of the opportunities to get involved. So PCORI is the Patient-Centered Outcomes Research Institute. And I think it's important to know, and one of our mantras within the organization is that we take the P in PCORI very seriously. So patients really are at the center of everything that we do in terms of how we think about our work, why we think it's important. And one of our board members even has described it as patients are our North Star. So really when we ask, you know what, I realized I can't see my own slides. Okay, so if I turn around, I'm not being rude. So the first question is, why was PCORI created? Well, PCORI was created out of the Affordable Care Act to be a comparative effectiveness research institute. And the reason, though, why they said that they wanted to have, and our board said that they wanted to have a research institute that really focused on the needs of patients is because traditional comparative effectiveness research has not really done that. So when you think about the fact that research asks a lot of questions, but it doesn't often ask questions that are important and central to patients. I think about the experience that I had. I am a physician, but I'm also, a mother, a daughter, a niece. And when my aunt had lung cancer, I, jumped in as the physician, doctor, niece, and said, okay, well, let's look at all of the different options that you have available to you. And so as I was looking at the research, I was interested in issues such as morbidity, mortality, the usual outcomes that we think about when we think about comparative effectiveness research. But my aunt was like, no, honey, listen, I'm 83, and I have to die of something. And the fact is, what my priorities are is I don't want to be in pain, I don't want to be away from my family, and I don't want to lose my hair. As she described it, that was her crowning glory, and she did not want to lose her hair. So for me, as the doctor, I said, okay, not necessarily the kinds of outcomes that I can easily find comparative effectiveness research on to determine how to figure out what was her outcomes. But when we think about what are the needs that patients have, we realize that people want to know what are the outcomes and what are the choices that are most meaningful to them. They also want to know, how can I get this information where and when I need it? So when you get that diagnosis for yourself, for your child, for a loved one, you want to have that information readily available to you. And so the work of PCORI is really meant to not only be research, but to be research that really focuses on the needs and the issues and the outcomes that matter most to patients. But we also have a component that's focused on dissemination and implementation, because that research needs to be where patients need it and when they need it. So this is our mission statement. What's important to know about our mission statement is that our mission is not to do research. Research is a means to an end. Our mission is to help people make informed healthcare decisions, and we do that through research. But most importantly, we do that from research that is guided by patients, caregivers, and others who are invested in the outcomes of patients. And so that's very important, because it's not just research because it's important. It's not research because it's interesting. It's not research because it's going to help some Harvard faculty person, and I could talk about Harvard because I was faculty up there. So it's not going to help us get promoted. It's research that is guided by and meets the needs of patients. And this is very important to the ethos of the type of work that we do and what's important to us. So for the purposes of today's discussion, I'm not going to talk about our research agenda, but just in a box, we have a very broad research agenda that includes issues such as options for prevention, treatment, and diagnosis. We have a focus on improving health systems. We have a focus on disparities. And I would encourage anyone who's interested in applying to us for research to come to our webpage and to learn more about that. In addition, we have a robust budget, so we are on target this year to award $400 million in grants. Next year, our budget is going to be around $500 million, and we are actually appropriated through 2019. So we have a nice window of opportunity right now to really make significant investments in comparative effectiveness research that means something to patients. But for the purposes of today's discussion, I'm going to talk about the work that we do in engagement. Because part of what we've said is, as an organization, it's not enough just to do the research. We also have to make sure it gets out to people who need it when they need it. And what we've decided is that engagement is the means to that end. When patients are involved from the beginning, when they are telling us what are the research questions, when we know that we are developing a research agenda that meets their needs, one, we are a trusted source of information as a result. Two, people know that they can rely on us because the research was developed with a patient perspective. And three, they know that we are answering questions that are meaningful to them. So for us, engagement is a very important part of the organization, and my charge as the Chief Officer for Engagement is to make sure that that is included in everything that we do. So engagement, people often ask me to define what is engagement, and I think the simplest way to describe it is engagement is giving someone a seat at the table. Not giving them an opportunity to provide input, not giving them an opportunity to give us some feedback, not asking them to maybe sit and talk to us one time or do a focus group, but it's truly a seat at the table to be involved at every step of our process. And so when you think about what we do as a research organization, there's basically 4 parts of the research cycle. So first is establishing our research agenda. And what we're thinking about is, what is it that we're going to study? What is it that we're going to ask people to work for and research for us? And so when we think about engaging patients in that process, we want patients to help to inform us what is it that we should study. But the next is the actual conduct of research and the review of research. And so we have patients who are involved with that, and I'm going to talk a bit about that. Third is our dissemination, because it's not enough just to do the work, but then once you have the results, you have to get it out there where people can actually use it. And then lastly, you have to evaluate yourself, because if we're going to have the kind of impact that we want to have, we have to make sure and test and evaluate ourselves to determine that we're having our desired impact. And once you have that evaluation, then it can inform the next round of research that you do. So I'm going to spend a little bit of time talking about how we engage patients in all steps of this process. So first is telling us what we should study. And the fact is that we have a very robust agenda. We actually have our webpage, and it's posted up there, where anyone, everyone can come to us and post their research questions. And we don't ask people to tell us, how to address the comparative groups and what are the variables that you want. What we do is say, just give us your ideas, give us your thoughts, give us the challenges that you have, and we can determine if there's a research question that is available. So we have a webpage that's available to this, but also we're going around the country. We're doing workshops with different key groups. And so we've had workshops that targeted Latino women in particular. We've had workshops that targeted nurses. We've gone around the country to hear people from different parts of the country. So we've been to Wichita, we've been to Memphis. I just came back from Albuquerque, where we're having regional meetings. We also are doing different types of roundtable discussions with different audiences, everyone from chief medical officers of health plans to, as I say, community groups in Chicago. And what we're doing is saying we want to hear from you, not from the researchers, but from the people who are the patients and the frontline providers who care for them. What are some of the challenges they have? And so we have a process whereby we take all of these questions in and we utilize not only our board, but our staff, our patient engagement advisory panel, anyone who's willing to come to us with an idea, and we take those ideas and have a process to winnow those ideas down. And so basically our process is this. We bring all those questions in from a variety of different areas, and then we evaluate them. Because someone may have a question, and it may be that the research was already done, but it hasn't really been disseminated well, or that person is not aware of the research. Or it may be that that question has been asked, and there's currently research that is underway at organizations like the NIH or at ARC. Or it may be that truly there is a gap in the literature, and there's a gap in research, and so that presents itself as an opportunity for us. So we then prepare topic briefs when we have these different issues and topics, and we really dig in and dive in to understand what are some of the issues underlying some of these questions. And then we actually then take it to our advisory panels, which I'm going to talk a little bit more about. And our advisory panels help us to prioritize these ideas and help us to determine what are some of the things that we should study. We then select from the recommendations that come to us from the advisory panels, and then we take the recommendations from our advisory panels, and then we take them to our board for approval, and from that we get our different ideas for what we should study. So recent things that we have approved, one of the things was the treatment of fibroids in women, but particularly for women who want to maintain their fertility and be able to continue to bear children. We've also done work and recently released a call on management of obesity, particularly with an emphasis on underserved patient populations. That was actually just released yesterday. We also have issued a call around managing asthma among African American and Latino patient populations. And again, all of this comes about as a result of the process where people are telling us these are the challenges that we're facing, and our advisory panel tells us, yes, this is something that should be prioritized, and it translates to a funding announcement. So from the perspective of our advisory panels, I wanted to just spend some time talking about that and to thank the people who have been involved with us on our advisory panels, people like Kim Bailey, who represent a variety of different perspectives. We actually have advisory panels for each of our major scientific areas, and they focus on everything from the disparities advisory panel to our comparative effectiveness advisory panel. Our board just approved an advisory panel on rare diseases. We have another one on randomized controlled trials. And one of the things that's written into the charters of all our advisory panels is that at least 30% of the people on those advisory panels need to be patients and other stakeholders. They need to represent the people who will ultimately use and make use of the research that we're producing. So obviously we want researchers, obviously we want clinicians, we want experts in a lot of different areas, but we want the people also who sit there and say, so what? This is not an important question. This is not the issue that I really worried about when I had this diagnosis, or when my mother had this diagnosis, or when my child had this diagnosis. And so our advisory panels are very important to us because they provide us not only with the scientific background, but also the real world, the patient experience background to help prioritize the different questions that we're thinking about researching. In addition, we have PCORI reviewers. And so similar to the NIH, we have study sections that reviews all of the proposals that come into us. But one of the things that we've said is that every study section should be made up 30% of patients and other stakeholders. And so every study section has patients who are there. And we've actually gone through a process where we train everybody to make sure that they not only have a seat at the table, but that they're really able to engage and participate fully in the discussion. And oftentimes people say, well, do you train the patients? And the fact is yes, we train the patients, but we also train the researchers, because everyone needs to be trained in order to understand that we all bring different types of perspectives and value to the table. And so when we at PCORI say that we expect our researchers to engage patients and others as partners in their research, we really mean it. And we have criteria for engagement, and we have developed some thoughts as to how to demonstrate that in the research. But we also said it was important for us as the funding organization to demonstrate that. So we have that by having patients involved with our advisory panels, as well as having patients involved as reviewers in our merit review sections. So it's just worth noting that these are the specific criteria that we have for our merit review when we do have research projects that come in. And we very specifically do not ask patients to try to become PhD researchers. What we want them to do is to bring their expertise as patients. And so the two areas that we ask them to really spend their time focused on when they're reviewing proposals is to look at this issue of patient-centeredness. Is the question one that is meaningful to patients? And one of the things that we have learned as researchers is we can ask a lot of questions in healthcare that often have very little to do with what's important to patients. And so the patients who sit on our study panels make sure that every question that we're seeking to answer is one that has meaning and relevancy to patients. But also they look at what we call the patient and stakeholder plan. So in every proposal that we have, people need to write what is their plan for bringing in perspectives, for making sure that patients and other stakeholders are involved, and is it a real and robust plan? We have language that says we do not accept tokenism. We do not accept just letters of support for these different projects. What we want is to see evidence that patients truly have a seat at the table and truly are involved with not only developing these questions, but the conduct of research through the end to the dissemination of the results. So the last thing that I'm going to talk about in terms of our cycle is the work that we're doing in dissemination and implementation. And the reason why it's going to be very quick is because we're actually making plans to do this. We've not yet developed our full and robust plan. But what I will say is that we actually just recently made a final funding decision, which we're going to announce in about a week and a half, as to who's going to receive this award that we're making to help us map out our plan for dissemination and implementation. But we are absolutely clear that once you have research, it is not enough just to get it published in the New England Journal of Medicine. That if we're going to have this research and really make it available to people who need it when they need it, we're going to have to really make a plan, a very deliberate plan to think about getting that research out into the hands of people so that they can use it. And so whether we're using social media, whether we're using patient networks, whether we're using patient communities that exist in cyberspace, what we're trying to think through is what is our plan to not only get the information out there, but to give people what they need in order to be able to use that information. So what I would say is more on this, and stay tuned, but what I can say with absolute certainty is that we will have patients who are involved with helping us to make that plan. So as I mentioned, we just issued or made the final decision about the award, and what we actually did is we took 2 representatives from our patient engagement advisory panel and had them sit down and participate in the review committee to help us make that funding decision as to who was going to receive that award. So again, we're trying to walk the walk while we talk the talk and make sure that patients are involved in every step of the way. So I just then want to take a few minutes to really talk about what is patient engagement and research, because this is something that we're hearing a lot from the research community, but what we're also hearing, particularly from patient groups and patient advocacy groups, is they're starting to say, well, these researchers are coming to us because you all are requiring that they have to engage with us, and so we don't know what it is that is expected from us. Is this something that's going to take 1 day of my time? Is this like a new full-time job? Exactly what is it that is involved here? And we need to be completely honest about the fact that we don't know. So we are the Patient-Centered Outcomes Research Institute, and I am the Chief Officer for Engagement, and I will stand here and say, if anyone tells you that they know how to do patient engagement, they're lying, okay? We are making this up as we go along. But what we are doing is approaching it with a sense of humility and saying we will try any and everything. We want to learn from the experience of people who've worked in community-based participatory research. We want to learn from the experience of the federal qualified health centers that have patients involved in their governance. We want to learn from any experience, the patient safety movement, where patients have been actively involved as partners. And what we're trying to do is try different mechanisms for involving patients and thinking about how can you involve them in research in a way that's meaningful. Also, what we're trying to do is evaluate ourselves, because what we have to think through is it really important that patients should be there when you're developing the question, but not so important to be there when you're doing the analyses? Or is it really important when they're there actually interpreting the meaning of the data, but not so important when they're going through the IRB review process? And so we obviously have some thoughts as to what really makes a difference, but we need to evaluate and really challenge ourselves to say that this is going to make a difference in research. And so what I wanted to share with you is the results of an exercise that we did where we looked at the first 3 rounds of projects that we funded. And again, these were projects that were actually evaluated by not only researchers, but also by patients who were part of the study sections. And they included engagement plans. And what we did is we read through 150 different research projects and pulled out what were some of the key lessons and experiences from those engagement plans that we can call not best practices, because we don't know what's best yet, but promising practices. What was it that was the experience from the field where people came to us and said, this is what we're doing for patient engagement and research? And basically, you'll not be surprised. If you read through this bulleted list, what you'll find is actually it reads through the steps of a research project. So whether it is helping to determine what needs to be researched, down to helping to write the proposal, down to helping to determine what methods are involved, helping recruit patients, to disseminating the results. It is patient involvement from the beginning of the project all the way through to the end. It is having a seat at the table. The fact is, though, is that among our 150 research projects, none of them did all of this. What they did is some did 1, some did 2, some did 4. None of them did all of this. And so we don't know. We can't say which one is better and which one is worse. But I think the take-home message that we saw when we actually went through this exercise is that truly every study had some ability to include patients in their work, and taken across all of the studies, we were able to see that patients were actively engaged in all phases of research. And so this is actually something that we're writing up now, because what we want to do is share the experience and share the practice, so that when a patient group or when a researcher is trying to think about how can we work together to engage patients in research, then at least we have a little bit of guidance to develop some common language around this, so that there's a shared understanding as to what might be the expectations for that engagement. The other thing that I wanted to spend some time talking about is the work that we're doing in terms of engagement, and something that we're calling the Engagement Awards, and give an example of our pipeline to proposals. But essentially, one of the things that we found is that early on we were giving these major grants, and so most of the grants that we're giving are around $1.5 million, major research grants with major efforts. But we kept hearing, as we went around the country, people saying, but I'm not a researcher, and I don't know how to get involved, and there's no training, there's no way for me to be able to participate. Or we would hear from clusters of community groups, people saying, well, we have some interest, but we're not working with any particular academic medical center, so how is it that we can get involved with doing this kind of work? And so we developed something called the Engagement Award Program, which was actually just approved by my board in November. And for any of you who are interested in applying to us for an engagement award, we're actually having a webinar on February 13th to launch the opening page for our engagement awards, as well as to provide details. But the bottom line is that these awards are really meant to be wraparound projects. They're not meant to be research. So this is not an alternative mechanism for trying to do comparative effectiveness research. But what they're meant to do is to be wraparound projects that provide support to the field to engage people in research and the research enterprise. We are particularly interested in what we call the non-usual suspects. So because I was at Harvard, I could talk about Harvard. If I see another Harvard proposal, that's not who we want to fund. What we want to fund are proposals from the communities. What we want to fund are proposals from systems. What we want to fund are proposals that actually come from patients themselves who had an idea and actually then went and recruited the researchers to help them carry out that idea. And so the purpose of these awards is to be able to do that, to help us develop an understanding of the different communities who we're trying to reach, to help us with training and development of different communities, and also to help us lay some foundational work for the activities around dissemination and implementation that we're going to be doing going forward. So these are relatively smaller awards. These are up to $250,000 over a 2-year period of time, and they're meant to be very practical, they're meant to be very real world, and they're really meant to help build capacity towards involvement with PCOR. And so as one example, we have a program called the Pipeline to Proposal, and actually this is a program that we just released the first round of awardees in December. And this was a program that we had where we kept hearing from people, we just need a little bit of support to try to come together. And so what this represents is actually 30 awards that we made to the tune of $15,000. It's not a lot of money, but it's the money that I call the donut and community center money, where you have, say, a group of patients who have a common condition or a common experience or come from a particular community, community. And this is just money to bring them together, to give them an opportunity to talk about different issues and to try to think through what might be some type of research projects that they might be interested in developing. And so we have everything in here from how do you prevent infant mortality and crib death to how do you manage a patient with Parkinson's disease in rural America. We have a wide range that looks at managing the elderly to managing diabetes. And so the range of conditions that people said that they wanted to manage was quite broad, and I was very pleased. But it also, some of these proposals came from patient groups, some came from primary care clinicians who just said, I see something among my patients and I want to have just a little bit of support to try to think about it. Some came from even departments of health. But the whole purpose of this is to really just provide a little bit of seed money over a 9-month period of time to give people some space to start to think about research projects. Then the subsequent levels that we're going to have, which have not yet been released, but they will be released later this year, are what we call Tier 2 awards and Tier 3 awards. And basically, if you think about this as a continuum towards becoming funded by PCORI, the Tier 2 awards are really meant to say, okay, so you have a cluster of patients and you have a cluster of clinicians who might have similar interests. Here's an opportunity for them to then come together and start to think about a particular research project. And so those awards are for $25,000, again, over a 1-year period of time, but to give people a little bit of space to do some of the thinking that needs to be done. And then the Tier 3 awards are meant to be a little bit larger. Those are $50,000 over a 12-month period of time. But again, those are the ones that are really meant to let's help people build these teams so that they can submit a proposal to us. Anyone who's done real patient engagement or real community work knows that it takes time. It takes a little bit of support. And so if you're that frontline clinician, if you're that doctor who wants to work in a particular community, this just buys you out of maybe, 1/2 day a week so that you can make that trip and go to that community. If you're a mother who's trying to bring together a group of other mothers who maybe experience a medical error or something like that, this is that money that helps you to pay for childcare so that you all have the time and ability to come together to talk about different issues. But the way that we think about it is that people should be able to start in Tier 1, progress to Tier 2, progress to Tier 3, and then ultimately apply to us for funding. And so this is our response to that cry that we heard, that patients said, we really want to have a seat at the table, but we're not yet well trained and need to have some ability to build up our capacity. So overall, the Engagement Award Program is a $15 million program, or $15 million per year program, and it is one where, particularly in 2014, the vast majority of our investments are going to be made in what we call training and development, in the area of trying to really build capacity for people, and particularly for the non-usual suspects to be able to come and participate in the work of PCORI. So with that said, I will turn it over to my esteemed colleagues, and I just want to remind you, for those of you who are interested in PCORI, definitely to follow us on Twitter, to follow us on our webpage. We are hashtag hashtag PCORI. I also tweet from time to time, and I am hashtag ACBeal. And for those of you who are interested in learning more about the Engagement Awards, we're going to do our official launch on February 13th, so I invite you to join us for our webinar. Thank you.
Thank you so much, Dr. Beal. That was really inspiring, and the work that PCORI is doing is truly innovative, and it truly does offer an opportunity for all of you who are working in the States to engage in research in a way that hasn't been possible before. So if you are interested in doing one of those grassrootsy things, do. I mean, this is a wonderful chance to get funding for it. Also, the engagement as a merit reviewer is an awesome experience that I've had, and the panels as well are a great way to engage. So if anyone in the room is interested in the work that PCORI is doing and the engagement efforts that they're interested in, please feel free to reach out to me as well. Next, we are going to hear about a model that has been proven to be highly effective at reducing disparities in health outcomes by ensuring that patients diagnosed with conditions such as cancer receive timely, effective care. When we think about innovation, we frequently think about what is new and high-tech. The model of patient navigation, pioneered by Dr. Harold Freeman, shows that what is truly innovative doesn't necessarily need to be high-tech. Instead, by focusing on the elimination of barriers across the continuum of care, patient navigation employs a high-touch method of connecting patients with all of the resources that they need to get the best care possible. Dr. Harold Freeman, like Dr. Beal, wears many hats. He has a Patient Navigation Institute in his name. He is also the president and founder of the Ralph Lauren Center for Cancer Care and Prevention. He's a senior advisor to the director of the National Cancer Institute. He's on the board of trustees of Howard University. He's a former president of the American Cancer Society, and he's on far too many boards and panels to name here. It is a great honor to introduce Dr. Freeman.
Thank you very much for that introduction. It's an honor to be here, particularly with these two colleagues who are really outstanding people. I've been a cancer surgeon in a poor black community for about 40 years, and so my experience comes out of that experience. And I want to first say that there's a disconnect between what we know and what we do for people. A disconnect between discovery and delivery. A good example of that is in the field of cancer. In 1971, President Richard Nixon declared a war on cancer, signed the National Cancer Act, a very good thing for a president to do. He put a lot of money into cancer research at the National Cancer Institute. The president said in 1971, this war will be over in approximately 8 years. Well, that didn't occur. One of the reasons it didn't occur was there was not a good concept. The war was declared in a way that if you found a magic bullet, you could solve it and it would be all over. That did not occur. He used the example then of putting a man on the moon. And if you put a man on the moon, you've done that. But cancer and other diseases are much more complex than putting a man on the moon. So there's a disconnect between what we know and what we do. I came to Harlem in 1967 as a well-trained cancer surgeon, and I became very, very frustrated early on because I was facing people, particularly women with breast cancer, a particular interest of mine, who were coming in too late. I saw women who were presenting at the first visit with ulcerated, bleeding masses. Can't see the breast. Very frustrating. It made me look to the community to ask the question, who are these people? And why are they coming in late? And that led to the things that ultimately led to patient navigation. The women who came in for what I thought was the first visit had tried to come in before. They'd come in often through the emergency room and waited long periods of time and finally got to see a doctor who told them, you're in the wrong place. This is the emergency room and you don't have an emergency. Go downtown 100 blocks south to get a Medicaid card and come back. That was the kind of experience that drove my thinking. At a certain point in 1979, I found ways to provide free screening for breast cancer in Harlem at 2 different sites so that women didn't have the problem of paying for mammography, and that was a good thing. It began to have some good results. But it didn't solve the problem because mammograms, after all, do not cure breast cancer. They may diagnose breast cancer but not cure it. I had the privilege of holding hearings as president of the American Cancer Society in 1989. Hearings on cancer in the poor. We heard the testimony of American people from all 50 states who had 2 characteristics. They were poor and they had cancer. The question is, what happens to people who are poor and have a lethal disease? And they told us some things that led to changing in our thinking. The poor people, whether they were white or black or Native American or Asian or Hispanic, said the same thing. They said, we meet barriers when we attempt to get into and through this complex healthcare system. Barriers. Typical barriers were financial barriers. Half of the people in Harlem had no insurance, for example, financial barriers. Communication barriers. People don't really understand what medical people have said to them, even though they don't say they don't understand. Barriers related to the sheer complexity of the healthcare system itself. Even for people who have knowledge and money, it's a very complex system. And barriers related to fear and distrust. So in 1990, with that background, I came up with a concept that I call patient navigation, and I want to tell you a little bit about it. Patient navigation. What I did was to bring people from the Harlem community, carefully selected because they were smart people, they understood their own community, they spoke the language of their community, they were of the culture of their community. I didn't care much about how much formal education they had. I brought them into Harlem Hospital and called them patient navigators. I put the navigators in the room with the doctor on the initial visit. The navigator would be observing the dialogue between the surgeon and the patient, and the nurse would be standing by for medical reasons. And after the doctor made a recommendation, which doctors always do at the end of a visit, the navigator would take the patient to a different room and ask certain questions. Did you understand what this doctor said? Often, the patient did not understand. Is there any barrier to your getting the biopsy of the breast that is recommended? The patient may say, I have no health insurance. Then we have to solve that at that point. Or the patient may say, I understand everything, I just don't trust the people here. Fear and distrust came up very, very big. Whatever the barrier was, we set out to solve it at that time. We developed something called patient navigation, which ultimately changed the outcome in breast cancer in Harlem from a 5-year survival of 39% to a 5-year survival of 70%, and changed the initial diagnosis stage from 6% stage 1 to 41% stage 1. This information was ultimately presented to the Congress, to the President, and led to the signing of the Patient Navigation Act in 2005 by George Bush. And that is how this issue got on the table. I want to show you a few points. Big picture, what drives disparities, in my view, whether people have resources, the top circle, the poverty circle, how people behave, the circle of culture. And culture is not necessarily negative, it could be positive. For example, the Seventh-day Adventists live in a culture in which they have positive results. They don't smoke. They don't drink. They eat vegetables. The Seventh-day Adventists, for example, have the longest lifespan of any other group in America and the lowest cancer rate, even when they're poor. So culture is very important. People in Harlem, New York, and Harlem, Kentucky, which is Appalachia, smoke heavily, drink heavily, eat the wrong diet. That drives disparities. Then there's a circle of social injustice. I don't have time to go deeply into this. But to the extent that any group of people have been treated unfairly in our society, that drives disparities as well. The big picture is this: overlapping people who don't have resources, overlapping people who have behaved in negative ways, people who have not been treated fairly, driving disparities from prevention, detection, diagnosis, and treatment to the end of life. And that's the very, very big picture. Discovery, delivery, disconnect, I've talked about. Here's a picture that shows that certain groups of people in our society have a higher rate of poverty, blacks and Hispanics, for example. Here's a slide that shows who is uninsured. There are now 50 million uninsured American people and 47 million poor people who overlap. That's about to change, I think, with the Affordable Care Act. We can be very thankful for that. Affordable Care Act is about to change this picture big time. But remember this: it's not enough to have health insurance. There's a difference between health insurance and access to timely, quality health care. We need to do two things: insure people and assure that they have timely access as well. Some of the other barriers that were pointed out in the hearings are listed here. People who are poor tend to be fatalistic. They don't even try to access the healthcare system that they cannot pay for it. Poor people often say the educational programs that we promote are insensitive and even irrelevant to them. After all, if you tell a group of people in a poor community you need to have a mammogram, but they can't get it and they can't pay for it, it doesn't make it better, it may make it worse. Here is the first patient navigation model that I created in 1990. And notice that navigation began at the point of abnormal finding, the first yellow line on your left, and ended with resolution in between diagnosis and treatment. The problem was that we had already found a way to do the mammograms at this point, so it wasn't the issue of could you get a mammogram, it was the issue of did you have a finding, and if you did, could we resolve it rapidly? So navigation is resolution of problems included. And here are the Harlem findings, which I've talked to you briefly about. I'll quickly review them. In a 22-year period ending in 1986, we saw 600 women with breast cancer in Harlem. Only 6% had early breast cancer, and half of them had late breast cancer. Those women had a 39% 5-year survival rate when it should have been 85%. After screening and navigation, as we show here, and published both reports. After screening and navigation, we changed the early breast cancer diagnosis from 6% to 41%, and the late diagnosis from 49% to 21%. And finally, the result was reflected from a 5-year survival change from 39% to 70%. It was this information that was presented to the Congress and to the President, and then we changed the model to a broader model, not just from finding to resolution, but from where you live to when you die. So we can navigate people across the entire healthcare continuum. There's an outreach component. We have to be concerned about getting people in for examination, but don't stop there. See that they get the examination. And then when they have a finding, see that they're rapidly resolved to diagnosis. If they have a diagnosis, navigate them through treatment in a timely way. After that, they're still alive, navigate them to the end of life through survivorship. And that is what we now believe is the model. And here's the President of the United States, George W. Bush, signing the Patient Navigation Act in 2005. And you notice the President appears to be happy on this particular day. The work that came out of Harlem. My time is short, so I'm not going to spend time on this historical timetable, but I will say that this program has gone a long ways. Patient navigation is supported in the Affordable Care Act. I was here earlier today. I heard Ms. Warren, who was very inspiring to me, talk about navigation in Michigan. The Patient Navigation Act requires that navigators be used to assist people who are uninsured to get into insurance through the exchanges, and that's being done in Michigan and other places around the country. The American College of Surgeons last year determined that for a cancer program to meet its approval beginning in 2015, it must have a patient navigation program. So these things have gone a very long ways. I'm going to end my remarks with what I consider to be the principles of what I call patient navigation. Patient navigation, number one, is a patient-centric healthcare service delivery model. It's not enough to have Medicaid, for example. In fact, if you measure Medicaid in cancer, the mortality rate of people on Medicaid is no different from the people who have no insurance. Something else has to be done. Just insurance is not enough. Patient centricity. Patient navigation has the power to virtually integrate a fragmented healthcare system for individual patients. For example, at the Ralph Lauren Center, which I founded 10 years ago, we give chemotherapy, but we don't give radiation therapy or surgery. The navigators at the Ralph Lauren Center are responsible for the patient even when they're sent elsewhere, and make sure that we close the loop. It's like a mile relay. To give you an example, there are 4 runners in a mile relay carrying a baton. Let's assume that the baton in this case is the patient. The first runner, and when you choose people to run in a mile relay, you choose people who can run fast, and you choose navigators who can do this work as well. The first runner takes the baton, passes it to the second runner, and if you can't drop the baton, you've got to hold it and run with it. But for the patient, who is the baton, the race is not over until it is over for the patient. It's not enough to work in a specialty area like a surgeon, which I was and still am in Harlem. I could do my work as a surgeon, but that wasn't enough to prevent people from coming in late. We need to navigate people from a beginning point to an end point when they're taken care of. The core function of navigation is removal of barriers to timely quality care, financial barriers, communication barriers, system barriers. Delivery of services needs to be cost effective, and it looks like data is coming out to show that navigation can help with cost effectiveness. Determination of who should navigate, the answer to that is, let's concentrate on what the patient needs in going across the healthcare continuum, and then assign people for that phase of activity according to what is needed. Therefore, navigators can be lay people, carefully chosen. Navigators could be nurses or social workers. Assign navigators according to what you're trying to accomplish in a given phase of navigation. So we make a distinction then between navigation, which is the entire race, crossing the finish line, and navigators who participate in phases of the work. That means, too, we need to have a coach. To have a winning Olympic team, relay team, you would need to have a good coach watching the whole race. We need to define where navigation begins and where it ends in setting up a system and say what those parameters are. And we have found that navigation can help in helping people move across systems. Most healthcare in America is given as primary care. Often there's a disconnect between primary care and tertiary care. But we have found that we put navigators in primary care and navigators in tertiary care and connect the navigators. You can, in fact, you can connect the systems through navigation, we find. Let me end with these brief remarks to say, I believe in the cancer field, and this can apply to any other disease, that no person in America with cancer should go untreated. No one would disagree with that. No person in America should experience delays in treatment that result in jeopardizing survival. And no person in America should be bankrupted by treatment of a disease. And yet, failure to pay medical bills is the #1 cause of bankruptcy in America today. Not acceptable. Martin Luther King, whose birthday was celebrated recently, said, "Of all of the forms of inequality, injustice in health care is the most shocking and inhumane." And here's another look at the patient navigation model extending across the entire health continuum, from where people live and how they live to when they die. Thank you very much.
Thank you so much, Dr. Freeman. We're going to wrap up today's plenary by hearing from a true innovator in driving change in the culture of care delivery, George Halverson. Like Dr. Beal and Dr. Freeman, George Halverson has a list of accolades and accomplishments that is far too long to cover its entirety here. But I do want to say that he is a true Renaissance person. Not only did he run the Kaiser Permanente healthcare system as the president as the chairman of the board of directors and CEO from 2002 through last year, he somehow found time to author numerous books on health reform and one on reducing disparities as well. In his two most recent books he has with him today are Don't Let Healthcare Bankrupt America, which is a read on the healthcare system and what we can do to reduce the underlying cost drivers in the system, and Ending Racial, Ethnic, Cultural Disparities in American Healthcare. In addition to doing all of that, he also found time to serve as an advisor on healthcare and financing to countries ranging from Uganda to the UK. And now he is president and CEO of the Institute for Intergroup Understanding. With that, I'd like to welcome George Halverson.
Thank you. Lovely introduction. I would like to talk a little bit about some of the topics that are in the two most recent books that I have published. One of them is called Ending Racial, Ethnic, and Cultural Disparities in American Healthcare. And that particular book talks about the fact that there are massive disparities in care delivery and care outcomes in this country and in various care settings. And it basically says that the driving forces behind the disparities, there are three major driving forces, and they all start with B. One of them is bias. There are all kinds of biased behaviors that happen. A second is biology. There are biological differences that actually change the risk for various diseases and various conditions. And the third factor that creates disparities is behavior. There are cultural differences, there are behavioral differences that cause different outcomes and different patterns of disease. And when we understand that all three of those issues exist, then we can take a look at any given disparity and do things to reduce the disparity. The Institute of Medicine wrote a superb study back in 2003 that talked about the healthcare disparities in America and talked about the fact that African American men were half as likely to get needed care for particular heart surgeries, those types of things. And they recommended in that study that if we're going to get disparities right, if we're going to end disparities in this country, we need to do a combination of several things that were really important to do. One of them was to build a database about all of the patients. One of them was to identify medical best practices. One of them was to track whether or not the medical best practices were being delivered, and basically argued for a data-based, information-based, patient-focused, exactly as you just heard described, a patient-focused model for healthcare delivery that had the focus of the care delivery on the patient and not on the billing systems and not on the other aspects of the system. And Kaiser Permanente actually took that study and implemented the major sections, computerized all of the medical records for Kaiser Permanente. So there's 10 million computer records. There's no paper inside Kaiser Permanente. All of the information about all of the patients is available all of the time in real time to the caregivers. Created an electronic medical library that has all of the textbooks, all of the medical journals that exist. And in addition to that, has 2,500 care protocols that are based on medical best practices for patients, and then does tracking of patient care based on race and ethnicity. So I could actually tell you last month the differences in immunization rates or blood pressure control rates by race and ethnicity in Honolulu compared to Sacramento, compared to San Diego, compared to Baltimore inside the system. And the system was set up to be data rich, so the doctors all get the information about the best medical science, but also get information about how well each site is doing relative to each ethnicity and ethnic group. So, because care is very local, care is very personal, care is very specific to a site. So if you track care by site, and you know that in Sacramento, your Asian American population has significant issues with blood pressure control, that gives you opportunity to do things. And we set up task forces that dealt with each of the areas of disparities and basically have reduced the disparities in just about every major area. But if you look at the book, you'll see that it shows what our disparities were. Because even in Kaiser Permanente, where we have the same, we own 36 hospitals and employ almost 20,000 physicians, so we've got a vertically integrated care system. Even inside Kaiser Permanente, there were differences between the populations when we started the study. Same patient, same doctor, same sites, same financial. I mean, there were almost no, the only variable was the variable we were studying, which was race and ethnicity. And we track race and ethnicity by over 100 categories and summarize it into some basic categories. And the board of directors at Kaiser Permanente gets all of that information as well. The board quality committee meets more than the finance committee or the audit committee or any other committee of the board, and the board actually has real-time on its computers at home what we call Big Q, which is the big quality study. They have 125 separate measures of quality in process that are available to each board member relative to the care sites. Now, the board doesn't micromanage, but the board uses that to monitor and also to inspire and then also to recognize the various places that have done the best job. So the care outcomes with that model have soared. There are 29 different HEDIS scores, where the number one score in the country and the world on a quality measure is Kaiser Permanente. That when you look at the Medicare ratings, we swept the Medicare ratings, had the best scores for all of Medicare. That's because the toolkit was there. It's because the commitment was there, but also all of the information. Medicine is an information-dependent science. And when the caregivers have information about the patient, caregivers can make decisions about the patient that are different than the decisions that have to be made when caregivers are guessing and when the reminder systems aren't in place. So it makes a lot of sense to have the tools. It makes a lot of sense to have the focus. It makes a lot of sense. We had some internal debate about whether or not it was politically correct or whether or not there were ethical issues relative to tracking race and ethnicity. And we decided that it was really important to do it. We needed to discover how we were doing, so we went through the ethical debate, did the tracking, and we are so happy that we did that because we've learned so much and had an opportunity to make changes in a whole series of things. So that's in that book. Quick comment about my books. All of the royalties from the books go to the community clinics of Oakland. So if you happen to buy one of my books, you're sending the money, the royalties, to the community clinics of Oakland. And if you buy the electronic version, 80% of what you spend will go to those clinics. So that's a good use of money. They're wonderful clinics, and they're really focusing on some patients that really need help. So that's the first book. Second book, the one that just came out, basically says, "Don't Let Healthcare Bankrupt America." And that's a book about healthcare costs. And the working title for that book was "Fix It, Damn It." It actually was I told people if I have to write one more healthcare book, it's going to be called "Fix It, Damn It." And it turned out I had to write one more healthcare book. But in the end, other people, wiser heads, convinced me that that wouldn't be the right thing to actually publish the book under. So it says, "Don't Let Healthcare Bankrupt America." But that book talks about major issues we have in healthcare in America. It talks about pricing as an issue. It talks about the fact that we pay more on unit prices than any country in the world. And in fact, our prices are so high in this country that they're 2 and 3 times what other countries pay for most pieces of care. And that book makes the point that if we paid Canadian prices for each piece of care in this country, we could drop insurance premium in this country by almost 40%. Because that's the difference between what we pay and what the Canadians pay for each piece of care. So there's a section of the book on prices. There's a major section of the book on the perverse business model we use to buy care. When we buy care entirely by the piecework model incents volume and not quality and not outcomes. The piecework model cripples reengineering, because if you're paid by the piece and you want to re-engineer a care process and you end up not wanting to use the same CT scan at 3 different sites, on the current fee model, that's 3 different revenues opportunities. If you re-engineer so you use one scan 3 times, you've cut your revenue by 2/3. So a piecework model basically is set up to discourage any kind of reengineering that creates any kind of efficiency. The piecework model also rewards bad care outcomes. When you have an asthma attack, in the piecework model, a lot of money is generated to the care delivery infrastructure. If you prevent the asthma attack, no money is generated. So there's multiple examples. Congestive heart failure, huge example, that all the opportunities that can happen. So the piecework model actually discourages innovation, and it rewards bad outcomes, and it also richly rewards screw-ups. Infections. The 1.7 million Americans went to a hospital last year and got an infection they did not have the day they went to the hospital. Those infections tend to be very profitable. One of the sad things about the infrastructure of care, no hospital ever would deliberately give a patient an infection. That's not happening anywhere. But if you do the right things and you really focus and you really put in process reengineering, you can bring those infections down to almost zero. In some cases, zero. And so the opportunity, but the financial model we have right now doesn't reward anyone for doing that work. It won't even pay anyone for doing that work. And on some of the things that you want done, if you end up doing some of that work and having it done by a nurse instead of a physician, you can also end up with something that can be labeled Medicare fraud. So we've not only made it difficult to re-engineer, in some cases we've made it illegal, which is not a good outcome. So there we've got, the book talks about that. It talks about how weak the toolkit is for support of care in America. The doctors don't have the information they need about the patient. They don't have the information they need about the disease. It's really, I'm on a task force for the Institute of Medicine, and we're trying to figure out in that task force how we can get all 90% of care in America to be based on medical science by the year 2020. And the fact that we are willing to say only 90% at 2020 tells you how bad things are today, to be based on medical science. It's really hard for caregivers to keep up, and most caregivers don't have good keeping up tools, and so the book talks about what those tools would look like. And the book also talks about a crisis we're having with kids, children in America. The first 3 years, the number one predictor for who's going to be in jail at age 18 is the number of words in a kid's vocabulary when they get to kindergarten. The number one predictor for who's going to be in jail, more than race, more than social status, more than economic status, and those are very heavy predictors, but the number one predictor is actually the number of words in the kid's vocabulary in kindergarten. And the first 3 years of life are when the brain develops. The children exercise their brain at that point. The brain builds, the neurons connect. The brains that get exercised in those first 3 years of life, when you do a scan, are measurably bigger and significantly more functional than the brains that don't get that exercise the first 3 years of life. And you can predict with 80% accuracy at age 3 whether or not the children are going to be able to read. And when you look at the children who aren't able to read and who have that, they're 40% more likely to get pregnant, 60% more likely to drop out of school, and 80% more likely to go to jail. And when you look at who's in jail in this country, 70% of the people in our jails either read poorly or can't read at all. We have 3 times as many people in jail as any Western country. We have 3 times as many people in jail if you look at France and Germany and England, all those other countries. And 70% of the people in our jails can't read. And 85% of the people in our juvenile justice system, the kids in the juvenile justice system, either read poorly or can't read. And you can predict by age 3 whether or not people are going to be on that trajectory. So what the book basically says is we really need, and half the births in this country are now paid for by Medicaid. We've gone from 20% being paid by Medicaid a couple of decades ago. We're now at 51% of the births in the country. And so that's in the Medicaid chapter of the book for that reason. And basically, arguing that what we really need to do as a country is we need to change the trajectory so that instead of having twice as many people going to jail, we end up having half as many people going to jail. And so we need to do those interventions. It's biological, it's medical, it's physiological, and it's sociological. And we need to give kids, we need to support parents in that process, because it's the parenting process, the direct parenting and supported parenting, that makes the difference for those kids. And interestingly, we're becoming bipolar in a different way. Many of the children in America, their parents are reading to them, they're talking to them a lot, they're getting all kinds of input to the children, and those children are ending up with the highest SAT, ACT scores in the history of the country. And at the other end, we've got an increasing number of kids who are illiterate, can't read at all. And so we talk about the bipolarity that exists financially, which is horrible. There's an even more painful possible bipolarity that's going on relative to functional ability that we need to address as a country, and we need to make a major issue. So that's also one of the topics that's in the book, and it's something that we need to address and have the courage and the insight and the wisdom, and we need to have the heart to address that particular issue, because sending kids down that path is not good. So with that, and it's our own darn fault if we don't do it. Now that we know what's causing all of those kids to have all of those deficits and to have those lives, it would be criminal for us not to do the things that need to be done to help those kids, because every kid you save is a kid you save. Every kid that has an intervention and and it's basically read, talk, sing. It's those three things: read to the kids, talk to the kids, sing to the kids. Read, talk, sing. And if you do that, it changes the trajectory and can cut the number of kids going to jail by half. And so that's something that we need to look at. But the part of the book that I was going to talk about that relates to this panel today deals with what can patients do going forward in relative to healthcare. And this book suggests, and what I strongly believe, is that a major change that we need to incorporate into healthcare is to give patients information that they can use to make meaningful decisions about care sites relative to the quality of care, because when that information exists, patients can make those choices and end up at the better care sites, and care sites will get better. Both of those things are true. And so when you look at issues like heart attack survival rates, and we need to look at things as basic as who lives and who dies. I mean, this is not just incremental change. This is life and death sorts of issues. And if we look at heart attack survival rates, there is a 4-fold difference between the best sites and the worst sites in the death rate. There are 4 times as many people. You saw some of those differences on the charts that you just saw a minute ago. There's a significant difference. When you look at coronary artery bypass surgery rates, patients who get that surgery should know what the death rate differences are, and there's a 4-fold difference in those death rates. When you look at something like sepsis, sepsis is the #1 killer today in American hospitals. Sepsis kills more people in our hospitals than cancer, stroke, or heart disease. Sepsis is the #1 cause of death in hospitals. And the difference between the best hospitals and the worst hospitals is your chance of dying in the worst hospitals is about 1 out of 3 patients, and your chance of dying in the best hospitals is under 10% relative to the sepsis. And sepsis is one of those areas where when the caregivers have the data and they have the information and they have it available to them, they can put care protocols in place that change the death rate. That needs to be done, but patients need to know that. Patients should know before they go to a hospital what the sepsis death rates are in that hospital. Patients should know that. Before I go to a hospital, I would definitely want to know what the sepsis death rates are from that hospital. Cancer is very similar. The differences in cancer survival rates are huge. Breast cancer, you saw some of those charts a few minutes ago. You are 3 times as likely to die of cancer in one set of care sites than you are in another. If you've got breast cancer and you want to live, you need to, and the book shows the differences and also shows some of the sites. But if you want to have cancer and want to live, you need to pick the right care site. If you have colon cancer and want to live, you need to pick the right care site. You need the right program for early detection. Early detection is critically important. And you need the right care site for medical best practices. And one of the things we found inside Kaiser Permanente when we started measuring the cancer death rates based on the cancer, we had some significant disparities between the care sites. And over a number of years, we've managed to bring the death rate down to about the lowest in the country for each kind of cancer, for each stage of cancer, by having the data and focusing on it and using it as something that we worked on and shared the science with all the right caregivers. Before we had that data, everybody thought they were doing the best job. Before that data was, because everybody had good intentions. Everybody had good intentions. Everybody had good hearts. And good hearts and good intentions are not the same as good data. Good data is what you really need. And so what we need in our care sites is great data. We need it available to the caregivers because the caregivers get better. When inside KP, when we started looking at the sepsis death rate, we had a sepsis death rate in our best hospitals, it was about 10%, our worst hospitals was about 30%. But the worst hospitals all thought they were doing a great job. They all thought they were doing it really well because they knew the science. They just didn't know they hadn't put the practice in place. Then when they saw the actual data, they looked at it and said, wow, we can do better. And some of the ones that were worst initially are now the very best in the entire system, well under 10%. That would not have happened without the data. You've got to have a data-rich environment to do that. And we need that same data-rich environment for all the rest of healthcare. People should not be dying because of low-quality care that the doctors are unaware of as low-quality care. So we should focus on death as, so the book talks about that, and I will end by talking about that, but we basically need to figure out how to make the care delivery system more accountable, and to do that we need to make it more transparent, and we need to make it more transparent in a couple of key areas, and one of the easiest things to measure is actually whether or not somebody died. And you can, all kinds of other quality measures have nuances to them, and if you're going to measure the death rate, you have to measure other issues as well because there are severity factors. You definitely need to know what the death rate was for stage 3 cancers, local cancers, each of the cancers. But once you know that, once the cancer caregivers understand that their death rate is higher than somebody else's, they can actually then improve their science, improve their practice, and consumers should be moving to the right care sites and going where best care is being delivered. So the book argues in favor of that. Yeah, and I think we should, and I recommend that you collectively promote that, promote transparency in those areas, promote accountability in those areas, and basically insist that the life and death issues ought to be a matter of part of the selection process for care systems and for care sites, and not be something that happens invisibly off the radar screen. So I'll close with that and open for questions. Thank you.
All right, we have about 10 minutes for questions. And again, if you fill out a card in the middle of the table with a question, hold it up and we'll come around and get it. While we're gathering questions from the audience, I'll throw one question out. And that's around actually getting these models into practice. Dr. Freeman, we know that patient navigation works. And George Halverson also mentioned, it takes a long time to get evidence to doctors and to get evidence into practice. So what can we do to actually speed that process of implementation so that we get models that work, like the patient navigation model and other evidence-based things that are going to make care better for patients into practice faster?
Okay, I think we do know that patient navigation works. The challenge now for patient navigation is that it's not within the policies of our healthcare system. Mm-hmm. There's some elements that are suggesting that it works. Affordable Care Act has some reference to it. But I think that the next challenge is if we agree that people, particularly people who are vulnerable, need special assistance and getting through phases of the healthcare system, then we should find a way to give them that support. Congressman Steve Israel in New York introduced the Patient Navigation Assistance Act last year. It didn't pass, but he's going to reintroduce it. If the act did pass, and we ask for support for Congressman Israel in the future for this, if it did pass, it would put patient navigators under Medicaid. In other words, we believe that something, call it what you wish, but we're calling it patient navigation, giving special personal help to people to eliminate barriers to timely health care should be within the policy of what is given under Medicaid. That's what we believe.
I would actually agree with that answer, and it is exactly right to go to the payer and change the cash flow, because if you change the cash flow, the caregivers follow. So whatever gets paid for is what gets done, whatever isn't paid for doesn't get done. And that's just basic reality. And I think that's exactly the right answer. Medicaid needs to come into the loop on this, and Medicaid needs to be paying for team care, insisting on, not even paying for, insisting on. Because one of the things that's happening in the country is Medicaid everywhere is going away from the old fee-based system. In every single state is going with some kind of purchased purchase Medicaid programs. They're now buying Medicaid in packages from vendors. And if you're buying Medicaid in packages from vendors, the secret is to set the specifications up so that the vendors have to deliver the things that you really need delivered. And if you write the right specifications, you can get a navigation system. And if you don't write the specifications, it won't end up in the system. So there has probably never been more leverage available for those populations of patients than is existing now because of the change in the practice of Medicaid. And it would really be a shame to miss that opportunity and not incorporate that into the purchasing model.
We have a number of questions about measuring quality, and that's sort of been a theme in our conference. Sort of to weave them together, to both of you, do you feel like at the current time the quality metrics that we have are sufficient? And if not, what do we need to do to strengthen and make the quality infrastructure more robust? And then sort of in addition to that, are the consumer-facing tools that are currently available to look at quality data working? And if not, what can we do to improve them?
That's your question.
I'd give a quick answer to that. The quality metrics that we have now are directionally correct but insufficient. It's a good thing that Medicare Advantage measures 55 measures of quality and service. That's a really good thing. Inside Kaiser Permanente, we've picked 125 that we think are relevant and operational and functional. And because we're a vertically integrated care system, we have the doctors and the hospitals and the labs and the pharmacies, and we're all part of a unified group. We can look at the total package, but looking at the total package, we've identified 125, and that'll probably grow to 150 over the course of the next year or so. And so, no, there aren't enough measures right now, and I can tell you for absolute fact that you have to get the information on the computerized, so that you can actually track 125. There's no possible, if you've got individual patients trying to track, or doctors trying to track 125 things by checking things off on pieces of paper, that's completely dysfunctional. That can't possibly succeed. But if you've got a computer system that's keeping track of all of those things and identifying whether or not certain things were done, and you're tracking against that, then you can do 125 without slowing down the process of care. So what we need is the information electronic, and then we need to know what we're going for, and then we need to have the combination to get to quality.
I agree. I fully agree with what you've said, George. I just add, there's a difference between quantity of care and quality of care. Mm-hmm. And our system pays for quantity of care, yes, but we don't pay for quality of care. In fact, we pay so much for quantity of care that we're wasting a lot of American society's money. We need to shift the money we pay for quantity of care to pay for quality of care.
I agree.
Sort of a follow-up along the same theme. In a lot of these reforms, we're facing resistance from various stakeholder groups. And when we talk about changing the way providers are paid, we frequently face resistance from the provider community. What can we do to overcome that resistance from the provider community?
That's your area.
Well, some of the resistance will not change on a voluntary basis in any way. I mean, basically, if the government through Medicare changes the cash flow for purchasing care, then caregivers will follow the new cash flow. Same thing is true on Medicaid, and the same thing is true in the private market. And that's what they were trying to do in the Accountable Care Act with the ACOs. The whole point of having accountable care organizations is to have organizations that are accountable for care paid for a package of care for a population. And once you're paid for a package of care for a population, you can re-engineer care. You can then change the care for your asthma patients to reduce asthma attacks instead of just paying for the asthma attacks as a crisis after the fact. And that was the intent of the ACOs. That's a work in progress. That is, we've not landed there in its entirety yet. Some sites are actually doing it really well. Some sites are failing. Some sites, but that is directionally correct. It is the place to go. It's the right way to go. And so that work needs to be done. So I think the ACOs and the medical homes both need to be supported as ways of getting there, because when you do change the cash flow, medical home can have a nurse making follow-up calls. I mean, we cut the broken bones in our seniors by 40%. We actually have 40% fewer seniors with broken bones. And we have nurses making follow-up calls to patients to make sure they're doing their prescriptions and to coach them on in-home safety. And Medicare wouldn't pay for that. If we billed Medicare for that, that would be considered Medicare fraud. But because we're prepaid with that amount of money, we can actually cut the number of broken bones by having nurses do that work. That's why the cash flow has to change, and it has to change so that other care sites can do that same kind of flexible work.
It's a tough problem because we're deeply embedded into a medical care system where health care is a commodity that you get if you can pay for it, and you don't get it if you can't, or you get it too late. That's the problem.
Yep.
I held a meeting in Europe not many years back, and an Italian testified to the president's cancer panel, and he was asked about health insurance, and he said he didn't understand what it was. And he said, they don't have health insurance in Italy. I didn't know that. So I was asked, well, how do you get it? He said, I'm Italian. And then so that was the subject. That was the answer to that. So it looks to me we're deeply embedded in healthcare system as a financial system rather than a quality of care system. And the shift that we're trying to make, I think, through the Affordable Care Act in part, but it won't solve it completely, is to pay people according to outcome. Pay providers, at least in part, according to outcome. You have to be fair with that, because sometimes doctors cannot prevent untoward outcomes. But I think the shift needs to be away from medicine given as a commodity that you get if you can pay for it, and you don't get it if you can't. It's a moral issue, because people shouldn't die because they're poor, and they shouldn't die because they're uninsured. That's a moral issue. It shouldn't be. But we're deeply into that. We need to change the system at least toward paying physicians and healthcare systems with outcome in the measure. To the extent if you don't get a good outcome, that should influence how you get paid.
If you pay a team of physicians in hospitals a fixed amount of money to take care of a given population, and then let them be flexible in how they use that, and then measure the outcomes of that process so you know whether or not the patients were dying, whether or not the kidneys were failing, whether or not patients are going blind. There's some very basic outcomes that can be measured, and you can penalize the care sites that don't deliver good outcomes. And caregivers are very, very, very smart. There's a lot of very intelligent people, and when empowered to think creatively about how to better use cash flow, there's some really amazing things going on. New Orleans, The woman who runs the New Orleans health system, the doctor, gave a brilliant speech, and she talked about when the entire infrastructure collapsed, and they had to, she said, build it as it grows wild in nature, and start from scratch. But they started with a lump sum total amount of money to work with, and then they just delivered the right care that was needed for the patients, and they didn't worry about each piece and the billing of each piece. They actually built a very elegant system that did a really good job for a lot of patients and actually ended up improving the quality of care, particularly in chronic care patients. And because they built it entirely around the patient, and then when, after the fact, they started coming back in and saying, now you need to go back and redo this, and you need to fit the Medicaid fee schedule. Now they're actually losing ground, and they're not having the outcomes that they had when they built it as it grows wild in nature based on the patient.
We will end there. We need to build the system as it grows wild in nature, and it will be more efficient. We've run out of time, so please join me in thanking our speakers.